We're beginning. Today is Endocrine Day, but a word from our sponsor. Uh, you may have noticed I posted grades. Now, I can't give them back because I still have two people to take the test. You probably don't want it back anyway. So, in order to get the grades so that thankfully everybody could pass and I would stop having indigestion, yeah, and the threatening emails just have to stop. Now I feel better.
What do you mean?
Well, you're here. I can show you the picture. Thank you.
Sorry, I was doing a little event.
Hey, it's okay. And so I was explaining how the grades got to be better than the many failing grades you should have had.
I probably brought that with that.
Yeah, oh, you are the only one.
You know, I love bunkers. I studied too. I studied really hard.
Well, you need to study harder. Okay.
Some
Here.
of us are at a disadvantage. We haven't even cell yet. Like Ava and I are in cell right now.
I didn't. I knew Ava was. I didn't know you were in cell.
What?
I knew Ava was in cell. I didn't know you were in cell.
Yeah. So some of the stuff that you were like, oh, you should know the cell, so I'm not even gonna put it on here. I was like, I don't know what the hell. All right, sure, great.
Well, I mean, yeah, it's the I can't make the course any different.
No, I know. I just was like, yeah.
So allow me to interrupt back there, ladies. The gang behind you. Yo. All right, here. So, see, and the two folks who didn't take it up there, Garrett didn't take it, Sarah didn't take it yet. So, what effectively, I had to. I took about 3 questions. I edited out to take more than one answer or throughout the question, and with limited exceptions, nearly everybody blew up the sequence question.
That
So-
was hard. What was the answer?
When the other people take it, I'll show you. Yes, sir. Yeah, I don't know which. And I threw. I guess one of the ones I threw out. So I mean, I gave. If you got basically, I go over the scantrons. If you get the answer wrong, you just get. I just give it back to you. You should see the way I marked it on the card. And then with the sequence question, I mean, if you got it right, I'm not going to penalize anybody. I'm going to give bonus points. But if you got it wrong, I'm not going to make all those wrong answers went away. So I mean, so you had as many as 8 points to get back. And with me giving back, it was up to 8 points in some instances. It got everybody into at least a passing or better level. So I felt that was fair. I would like to see the performance improve drastically. And that's saying quite a bit. So I'll try to get the next study guide out relatively expeditiously. I think as I recall last time we did, it's either 2 or 2.5 chapters. It's definitely autonomic and it's definitely endocrine, which we're doing today. I treat immune as a standalone almost in lecture, maybe with some other odds and ends. So the question is where I put the blood. And we'll be starting on blood surely by Friday. I think we probably have 2 days worth of immune. Maybe be able to introduce blood on Wednesday because we'll do like the EKG lab and finish heart downstairs here, and we'll go to the zoo lab next week and I think only one of us is supposed to be missing. I mean, I know Elena's gone because I just talked to Julia, and hey, you just can't win with everybody, but that's okay too. Moving on. So now after wasting 5 minutes, let's start. So we're going to delve into really the physiology of endocrine more than anything else. And I want to start back and go over them sort of hormone by hormone without, and even if there's a certain degree of review, that's fine too. So I thought we'd start here with the hypothalamus. So effectively, other than the sensor portion associated with the hypothalamus, when we start looking at it from a hormonal standpoint, that's where we probably looked at some of this stuff that was there. Because there are still 2 classic hormones that are directly into the bloodstream. That's the oxytocin and the vasopressin, which I do want to review because they're important. And then, some additional notes that are there. So all of the things that it secretes, the release factors, the inhibiting factors, are also effectively hormones. It's just they have a relatively short travel from the infundibulum stalk, where they basically are secreted from, and the neural hypophysis, known as the posterior pituitary, to the anterior pituitary. What makes this possible? Okay, there's a tract of nerves between the sensory area of the hypothalamus, albeit small, and into the posterior pituitary. From those two classic nuclei, paraventricular and supraoptic, through that stalk called the infundibulum, and effectively these go directly into the bloodstream. And that's the little note I have to add of why we make relatively rapid, not as rapid as nerve changes, but rapid changes associated with endocrine, because it's right in the bloodstream. So we have oxytocin, an antidiuretic hormone. I'll go over those once again. Here's the anatomy of it, not a big deal. So again, what surrounds this, as you will see, is a very elaborate capillary network. So this is another example, like we saw in GI tract, a portal system. A portal system is where you go from normally you go artery, arterioles, capillary, venules, veins. Here you're going from capillary bed to a vein, back to a capillary bed. Just like in the liver, where you go from the veins that are collected and become the portal vein from their capillary beds in, say, the small intestine, and make their way into the liver, form additional capillary beds different, and they're collected yet by another vein that becomes the hepatic vein. So portal is sort of vein to vein without arteries in the middle from an anatomical standpoint. And so because of that elaborate bloodstream network surrounding it, these go right into the bloodstream. And so things that go into the bloodstream are fairly potent, and these are examples of it. So this is what it is: the primary capillary plexus, the portal veins between them, and then the capillary plexus toward the anterior pituitary. And by and large, and not every aspect has a releasing and an inhibiting one. Okay? So those are little upticks and downticks, upregulations and downregulations for the major hormones. The one we talk about the most when we get to repro is GnRH, gonadotropin releasing hormone. There's not really a gonadotropin inhibiting hormone that's released by the posterior pituitary. There are other hormones that interact with that system, where the release hormones are much more abundant and impactful. I can't even read those things. So on the way here, so again, it's not important whether it's paraventricular for oxytocin or supraoptic for ADH. That's fine. Don't worry about that. But they are easily, we talked about it before, they are easily and are reproduced genetically as Pitocin and what's called DDAVP. Both used a lot. Pitocin for the longest of all those times to induce labor. And then the DDAVP, not only does it supplement people who have a lack of it, and we'll get to the disease condition where that is, it also is useful, again, this is vis-a-vis clotting abnormalities. And so because of my first wife's von Willebrand's, when she had to have anything, major surgery, even like a dental extraction, like an implant type of thing put in, she had to have this done. And at the time, it was quite expensive. Insurance paid for it. But I mean, this is, I'm thinking 2004. So 20 years ago, it was still like $600. Whether your insurance did cover it. So, yes, ma'am.
You appreciate this? My factor that I'm supposed to
Yes.
every other day for the rest of my life. One dose is upwards of $10,000.
Oh yeah. Oh, they're awful. They're awful. I have decided, when we get to immune, I'll tell you about the shot I take, the Humira. I'm sure I mentioned before. I'm trying to get away from it. I mean, I'm sure my rheumatologist would be beside. He's so busy he wouldn't care, but he'd care because he feels it's the best treatment. That's $6,000 an injection.
Oh yeah, it's crazy.
And
Especially when it's the only thing available to treat whatever is going on. And
the
it's
Humira's
lifelong.
got other things.
Right.
Thankfully, it's just desirable.
My treatment is the first and only approved treatment for my condition, and it was only approved in 2015.
Text me the name or email me the name. I'm just curious about it.
It's a Coagidex.
I'll have to look it up. I'll look up what the genetic basis. Fascinating. I mean, so understand and why I don't want to do it anymore. Look, the company wherever you guys work, wherever you're going to work in the future, if you work for a large corporation or if you work independently, these days everything has big co-insurances and big deductibles. So every year the first $3,000 comes right out of our pocket. I don't like that. Didn't used to here.
I'm
Yeah.
on Medicaid. My condition is qualifying to get me on Medicaid
Gotcha.
for life, and people like crap on government insurance, but Medicaid, I've never had an issue with Medicaid ever in my life.
Aside from what we're talking about, Medicaid, the problem is the compensation for the physician.
Right.
That's where it gets the bad rap.
Mm-hmm.
So we would do a private surgery on somebody, and it doesn't mean people with Medicaid shouldn't qualify. Medicaid's very useful when they have Medicare and Medicaid. That's a good mix. And what they do if you have an older relative going to a nursing home, they basically break them and put them on Medicaid. They suck up all their available resources. But if I did a surgery that I'd bill $1,500 for, I might get $100, $150. See, and your exposure is the same.
Right.
That's the way doctors look at it. I mean, I did one of those. I got sued for. And what did this gal? Look, it's always on you, okay? Because you have to think ahead. And her boyfriend was in a band. She comes, tells me a week after the cast I have on her foot after breaking bone and putting a pin in there is all broken. I said, "What were you doing?" "Well, I was helping my boyfriend move sound equipment. We had a gig he had." "Oh, great. That really helps me." And yet I get sued. Now, it was dropped because I had all sorts of, documentation about that. A giant note in the chart, wrote her a giant letter, I did the hospital where the Pens played over there. That's where the hospital was. The old St. Francis Central, the old Central Medical Pavilion. So which I think I got $100. And 2 ulcers worth of aggravation. Just, it's okay. It all turned out. I'm fine. I'm healthy. I'm doing better. Yes, you raised the roof. I hear you. It's okay. I'm getting there. Here's the oxytocin, positive feedback, always good to remember. And you can see there are some aspects of neurotransmitter in the brain as well that probably have something to do with sort of initiating and promoting that positive feedback loop. The ADH, very interesting. Now, osmoreceptors are just that. They're detecting osmolarity. And if they're too high, obviously you need to retain more fluid. And very simply, we talked about this at MCAT today. This inserts, and it's all about water, basically inserts little openings in the tubules and the collecting ducts in the kidney. When we get to renal, we'll go over this again. And you can see other things trigger that are there. So there's certain times when you retain these, it's almost in an effort to elevate your blood pressure would be the way to look at it. The big problem with why alcohol is problematic, it was a question we had today in the MCAT class, has to do with the fact that it inhibits this mechanism. And so people end up, and it really compromises them because despite drinking, you can become dehydrated because it blocks antidiuretic hormones. You're constantly urinating, and it can even and that can compound the effects of the alcohol. So another thing we call it vasopressin because it elevates blood pressure. Yes, and I apologize. So this is the clinical disease. We won't get to diabetes today, but we'll probably spend a day on Wednesday diabetes, so to speak. diabetes. Okay, there's two types of diabetes. This in the old days we called it salt diabetes. Classically, diabetes is sugar diabetes. Their names in Latin are different. Diabetes insipidus for salt, which is a deficiency in antidiuretic, and diabetes mellitus or mellitus, depending on how you pronounce it. I've heard both. Is sugar diabetes. So a lot of people will just say they have sugar, and the implication is here. But diabetes, everybody, means one thing: the great thirst. So why would you get the great thirst if you're urinating too much? The difference in and why they named it that way, the urine was disproportionately salty for this and disproportionately sugary for sugar diabetes, which is kind of, so basically it changes the chemistry of the urine would be the easiest way to express it. So in addition, now that we have the ability to supplement that, okay, with these injections, but again, good hydration is the way to go for folks who have this. It's not life-threatening as long as it's managed. So inappropriate ADH secretion, okay, periodically we see this. And then sometimes you have to be very cautious because it's tough to tinker with sodium and fluid levels in the other direction. It's easy. We have a way to easily get them back in, but when they get too high, that's more problematic. And then you're really playing a delicate game of balance, which finally brings us to the big six. All peptide hormones, growth hormone activates a slightly different mechanism by the CAMP second messenger system, but it's slightly different in that it does not use that mechanism. Let me check that text real quick. F of GD. Means I gotta go stop at Sam's on the way home. That's F a giant duck. So yeah, it's just an expression we used.
Oh yeah.
Hey, this is 50 years ago we said that stuff. It's sort of like a version of WTF. Okay, so other than the growth hormone, a little bit different. All the rest of them second messengers. It doesn't preclude it being peptide based. What I should have said to you. To me, it is tropic. I mean, I understand it's regulation of secretion, but tropic to me means growth. When something hypertrophies, it grows. When it's when it's dystrophic, it grows irregularly. When it's low growth, we call it hypotrophy. Or without growth, atrophy. So to me, that's a misnomer. I hate PowerPoint people. Growth hormone, somatotropin, body growth, as it produced by somatotropic cells. Direct actions on metabolism and indirect on growth. So this is the big deal again. You can't know this point too well. It doesn't use sugar. It uses fats as the energy source. Glucose sparing, okay, decreases use of glucose and its metabolism. It opposes insulin. When in a growth spurt, insulin is disfavored. Normally, insulin is the favorite approach. Our prime usage is carbohydrates. Liver breaks down glycogen into glucose because it's an activity of making at least more resources potentially available, but particularly fatty acids. Okay, and basically think of it from an athletic perspective: leaning and repairing muscle at the expense of fat. The ultimate performance-enhancing drug. Very difficult to assess historically, easier now. Okay. They've learned a lot over time in how to deal with it. It hasn't stopped it. Did you see that? I don't know what kind of performance-enhancing drug Jimmy Garoppolo got a 2-game ban. But I mean, they've been pervasive in sport for a long time. Unfortunately, some sports worse than others. Indirect actions: liver, skeletal, muscle, and bone to produce, and we call them insulin-like growth factors. What do? It act like insulin would act in if you were just consuming a regular meal. So uptake of nutrients, DNA and proteins, collagen and bone. Most cells enlarge and divide. The big players, bone and skeletal muscle. Athlete 101. So I mean, I've seen the results of this firsthand with people, and I've seen them in people make a scary transition. So how do we regulate it? Uptick, downtick, upregulate, downregulate by hypothalamic hormones. Okay, on those somatotropic cells, either GHRH or GHIH, either releasing it, low blood growth hormones, or glucose, or high amino acid levels, high protein intake. You want to start to utilize them. Okay. And that's kind of what you're trying to do with all those, the muscle milk and the protein powders and stuff like that. I don't oppose that, but I think you need to understand that you have to, assuming your kidneys work fine, hydrate, because you're going to be building up a ton of nitrogenous waste that you have to clear out. If you're going to utilize those things, if you're a diabetic, be very careful. I would get a physician's advice. Just saying. When I like in the original carbohydrate sparing diet, it's called originally it's called the Cambridge diet. Then it became South Beach and Atkins, and then then all of a sudden it went to keto, and they're all really the same thing. The idea was that you were having an overload of fat and then protein metabolism. You've got to get rid of that. There's a lot of waste products in your kidney, so hydration is an integral part. When I went on that back in, let me see, nearly 40 years ago, I went to the doctor. The first thing they did was a glucose tolerance test to make sure I wasn't a diabetic. Forget the doctor's name, but it was in Meadville, PA. Oh, really? I spent, 20 years practicing in Oil City.
Oh, really?
Yep. It's a Cambridge County girl. You probably dated hockey players. Good hockey program up there. I'm just saying. It's okay.
Like, don't call me out anymore. I'm embarrassed.
You had her like a book sign.
It's because I have a lot of experience.
Sure.
It's very becoming. I didn't mean to embarrass you.
It's okay.
It's okay. Yeah, my stepdaughter spent 4 years at Allegheny and all that stuff. Oh, I know that very well. You wouldn't be old enough for that restaurant. There was an Italian restaurant where something else is now. We used to go to. There's no place to eat up there.
It's not there anymore?
Nah.
Is it called Jody's?
It's something else.
Something else?
With an S. It's going to come to me. It's okay. Yeah, I'll get there. It's all right. Hey, you probably went to the Crawford County Fair.
I live
Right up the hill. Hey, these are District 10 people. Here for sport. There's a guy here from Oil City. The guy, he's older. He's probably pushing 40 with a beard. Sits out there in the area. I don't remember his name.
Oh, Andy?
Yeah, big. Yeah, I think he's Oil City. Because my son, the one I showed you in the picture, he still has contact. We left there in second grade. I practiced there longer, but he still stayed in contact with some of the guys he was swimming with and doing sport with and stuff like that. The old David Mead Inn. Is that still there?
Yeah.
Yeah. We used to have like meetings there for the medical society. Moving on. So we have the growth hormone releasing hormone and the inhibiting hormone. So what triggers this? There's a hunger hormone that will also do it, that plays a role in this because you figure you're eating companionally, particularly if there's a need exists there. So there's not a lot to say about this. And you can look at all these things, and I am not going to go. The big deal for us are hypo and hypersecretions, which are rare. Okay? And it's all about the bones and the growth plates. If the growth plates are open and there's typically a tumor or some unusual condition, you get gigantism or giantism. I've seen both. In adults, it's a very odd condition after the plates are fused called acromegaly. Acro means the tip areas, and they don't elongate as much as they thicken. Predominant chin, face, hands, and feet, not so much long as wide. It's a very distorting kind of a look. So you don't, and so, and again, most of the time, tumors are the result. This is more common, pituitary dwarfism. We used to have no means to treat that because remember, we couldn't make growth hormone genetically. They had to extract it. Typically, it was not human-based, like insulin was not. And so and they reserved that because there were reactions to it. Friends of ours, there's another city up in the area, Elwood City. Friends of ours who lived in Elwood, my first wife was very friendly because they went to nursing school, Slippery Rock together. They were both of normal stature, as were all of their children, save one. I think they had 2 girls and a boy. And the boy was very diminutive. And we're like, we're all medical people. It's like, what are they looking at? Well, when they measure kids pediatrically, you get those charts, the length and weight charts, and there's a formula. It's only when they're at a certain age, at a certain level, where you start to, where they're at the 25th percentile, then you start looking at that stuff. When they might supplement with this. We have had a student here, a wonderful student, who's now, she was in like my second class. I was even full time. Who my stepson went to school, who had that. Very athletic, but she was diminutive, but very, very athletically oriented. So in adults, it's not, and they always show you the same picture. Okay, thyroid, TSH, really important. Last time I had my physical last month, one of the 8 tubes of blood were thyroid. Okay, thyrotropin or thyroid. So tropin, growing the thyroid, normal development and secretory activity. There's a release hormone. As you can see, the inhibition is indirect by growth hormone inhibiting hormone. So we don't have a thyroid THIH or TSIH, whatever they would call it. Inhibited by rising blood levels, and principally the thyroid regulates itself. And for most of us, it's not a problem. As we excrete more and there's an abundance, it slows it down. It's good old negative feedback 101. This is what we call the arc. Hypothalamus reads those levels. If they're low, it causes the release hormone to trigger the anterior pituitary. It stimulates the thyroid, and the hormones feed back on both of those levels. And target cells, for the most part, and nearly every cell in the body is a target cell for thyroid. Thyroid basically keeps everything running at the appropriate rate. So if it's not functioning properly, it affects reproductive, heart, kidney, you name it, digestion. And there's certain, ways of getting an idea if somebody tends to be on one side or the other. Low thyroid is very easy to treat because we've had thyroid supplement has been around forever. High thyroid, not so easy. We see it in animals, and we had a cat that was taking something to lower the thyroid because the cat was just getting tinier and tinier of the mini cat population. Hard to pill the cat. Dog, hey, peanut butter goes long. He's into the peanut butter.
So what?
Peanut butter to pill. Just skippy around that bad boy and stick it in his mouth. He's a happy camper. He's a happy camper now because he's at Camp Bow Wow. Okay, ACTH, adrenocorticotropic hormone, is really the other one. They'll get to the thyroid specifically later. ACTH, very interesting chemical. Okay, precursor to corticotropin and is or precursor to opiomelanocortin. So what that means, and we're going to get to this later when we look at the adrenal gland, there's a relationship between certain kinds of pigmentation presentations and adrenocorticotropic function. Very interesting disease associated with that. And we will get there. So adrenocorticotropin stimulates the release and releases corticosteroids of the adrenal gland. So it stimulates the adrenal cortex and it releases corticosteroids. You're going to see all the one when we get there. So there's a CRH, and it's very much part of your daily rhythm. There's a lot of different factors that alter it. Fever, it's just basically your response to stress is just like fight or flight. It's the adrenal medulla. At the same time, your response to stress also is the adrenal cortex. It releases sugar, it retains fluid, okay, and in that case raises your blood pressure. So they're interlinked, and it's a fascinating gland. Fever is a time of stress. Hypoglycemia, you need sugar to fight off whatever is going on, and any stress in general that are there. And you need to remember that. This, for those of you who have or endeavoring to go into medical-based fields, this is an interesting nugget, something you learn very early in professional schools. It's about steroids. Okay, a lot of people for years now, we were just talking about these what we call biologicals, that coagulant agent of yours, Mason, and the mirror of mine. Those are generically they're called biologicals. They're laboratory made. For years, the only treatment for a lot of abnormalities, particularly immunological abnormalities, were steroids. You had varying levels, sometimes daily steroids. They had dose packs, which are used so commonly, a lot of times for acute inflammation. There wasn't a whole lot you could do because we knew that calmed down the immune system. We're not even sure of the mechanism. Generically stabilizing membranes. What happened with those dose packs? Everybody familiar with what a dose pack is? If you're not, it's like, oh, I got poison ivy. It's killing me. I'm going to scratch myself to death. Give a dose pack. Contact dermatitis. Give a dose pack. Basically, it's called methylprednisolone is the name. Medrol is the name. It's the generic name for the trade name for the dose pack. And you take 6 pills, and it's over 6 days. 6, 5, 4, 3, 2, 1. And so, like maybe you take 2 of these 3 times a day, and then you begin to take them away. By the time you get down, now this one would be BID, morning and night, AM and PM. The last pill you take is in the morning. And this is the interesting thing about steroids. Because the reason as you take it away, you don't want to alter this mechanism. So we know the levels are high in the morning. So if you're going to have discontinue them, you want to discontinue them favoring the morning so it doesn't impact this. If you would discontinue in the evening, you would have low levels in the morning, and that could really impact people's function. So when we had patients we were going to operate on who were steroid based, I'd call up their family doc, their internist, and say, we're going to do an elective surgery. How do you want to handle the steroids? And they tell me specifically exactly what it was. So you don't want to alter these rhythm mechanisms, these daily rhythms or monthly rhythms. If we're talking about menstruation, you got to be so cautious with that. And it's not just because you're going to go because some of you are pre-meds. It's everyday stuff. You all have people, and people get sick, people get better, people have problems. Typically, they're going to ask you, because you have some knowledge, to come in and answer questions. I got stuck with that job early. That's what they do. If you have some degree of training, there's people in the family go, well, the doctor told me I needed this. What should I do? These days, people look stuff up, but then they doctor themselves. There's an old saying, a person doctored themselves by Reader's Digest. That was a publication that took little articles from all over, and died of a typographical error. Not a great joke. It's an old joke. Ugh. You couldn't swear before. The jokes had to be inherently funny.
You still could swear you want.
No, but you can't do that in the old days on TV. Nobody got in the Ed Sullivan show and said, he's like I'm watching an HBO alleged comic. So FSH and LH, this is all reproductive. They're critical. We visit them again. The follicle, straightforward enough. Eggs and sperm. Luteinizing, estrogen, progesterone, testosterone. Okay, gametes are sperm. Females, mature, plays a role, a very important role in ovulation. Follicular maturation triggers the release of estrogen and progesterone for sure. In male, it's about testosterone, secondary sexual characteristics. All of the above are part of it. So collectively, they're gonadotropins. It has to do with, again, this very famous release hormone from the posterior pituitary, GnRH, which really doesn't start to go until a unique situation occurs at puberty, which is, it has to do with lack of sensitivity to rising levels of, so that as testosterone and it's almost like the hypothalamus becomes very sensitive, and all of a sudden it's like an explosion, like a rhythmic uptick of this. It's very unique, and there's a lot of variation. And I commented on to the MCAT folks because we've seen a change. It's earlier now, so there's always been a concern about foods. And I'm not sitting here telling you got to buy organic because you still, somebody could put a label that says organic on it. People aren't above that. But I am concerned about antibiotics with regard to allergies and sensitivities. I'm concerned about additives to food. It's about your budget. So I always tell you, you got to find a place where if you want to buy organic, you got to find a place that's affordable. I can't pay $7 for a red pepper. I just will not do that. Just, yes.
I was waiting.
At Walmart yesterday, I paid 78 cents for a great avocado. That's a bargain.
You can get them at Aldi for that price.
I know. I go to Aldi's all the time. If you're going to buy organic, go to Aldi's. To this day, we had a big family. There's no Aldi's. If you did not know, Aldi's owns Trader Joe's. That's their upscale line. Aldi's a German company. And what they do is their high-end line is Trader Joe's. Okay. So that's their all organic, good stuff. People are label shoppers. It's the same stuff. Are you kidding me? Shredded cheese is shredded cheese, whether it's from Aldi's, Happy Farms, or it's.
You shouldn't even buy shredded cheese. It has that wax on it.
Oh, I know. It's all.
You should just buy the blocks. Get a shredder, yeah.
Get the old shredder. Get the old box grater.
Just get the one where it's like you put it in, turn the handle.
Oh, that's so fun. Get the box grater. Back to the old days. Used to have a toaster that looked like that on the stove. That's how you toasted before we had an electric toaster. We went on a vacation and they didn't have a toaster, but they had one of those things on an old gas range. The first and only go away my folks ever had. My dad worked 6.5 days a week. Why he went to a freezing place in the White Mountains in New Hampshire, I'll never know. It was inhabited by New Yorkers. Prolactin. Anterior pituitary, least understood, everybody. Yeah, we know the role with milk production. Okay, the role of male is not. It clearly has some aspect that is involved in reproductive overall health would be the way I would describe it. So typically it's inhibited. The most interesting thing, and they'll show it to you here. Another one we learned about. Anterior pituitary is a gland. Glands get tumors a lot. Okay, the one that inappropriate lactation. If a woman, or certainly if a male, would start to lactate, the first thing you have to check is whether there's a pituitary tumor. For whatever reason, that releases prolactin enough to start that. It's a very odd scenario. These are the kinds of things you're always in medical, they're back of your mind things. And to me, that's how you put puzzles together, particularly diagnostic ones. Reason behind breast swelling and tenderness during the menstrual cycle, I'll buy that. Rises the end of pregnancy, yeah. Suckling stimulates it, I'll buy that too. Hypersecretion more common than hypo. Not a problem in anyone except women who choose to nurse as hypo. Okay, again, inappropriate lactation and these other signs, infertility, menstrual difficulties, impotence in males, certainly point toward that tumor. Okay, here it is. Hyperprolactinemia, very notable. One of the things you check for. If you saw that, I mean, then you got to do an MRI and see if there's a tumor. Just got to. So that's everything for that first. I do want to introduce the second one as we get started here and finish. Like I said, diabetes will be tomorrow because these other ones go relatively quickly. Okay. And the first one is the thyroid. So it's an easy one to do comparatively speaking, but so important. Easiest one to find on either side of your Adam's apple with a little strip called an isthmus, sort of like Panama. Yes, that's an isthmus. In the old days, you say this must be my lucky day. Little Rascals, 1938. Yeah, isthmus, a little mass between them. Basically, they are follicles and they're classic glandular look. So epithelial follicular cells that produce a glycoprotein, which is the precursor to thyroid globulin. And it forms when it collects inside a lumen. Remember, it's a gland. It's still a gland, whether it has exocrine or endocrine. And what happens, you have cells that encircle this thing we call that create the follicle with a hollow interior, and it accumulates thyroid globulin. That's thyroid globulin that's ready to go and eventually be rapidly transitioned to T3 and T4, which are the active forms that are secreted into the bloodstream. There are additional cells that make calcitonin. You might remember that from bone. That tends to, particularly active in children, stimulates bone to be laid down and imposes parathyroid hormone, which we'll get to, that causes calcium to be effectively increased in the bloodstream by breaking it down in bone, absorbing it from the gut and the kidney. So it's nested by blood vessels. Again, these are endocrine, so they have a ton of blood vessels. That's the interesting part. The toughest thing thyroid-wise with all those blood vessels is you have to remove a thyroid, and we do for thyroid tumors. Easy to treat because you just remove it and use thyroid supplements. If you're going to have to get a cancer, that's one of the ones that should be on the top of your lists because it's almost 100% curable with those methods. We would take that out, and in the old, this is because I had surgeons who were operating in the 40s and 50s. We'd have this massive tissue clamped to like 30 little tiny hemostats. And then we take it out. And because there was so much risk of bleeding, the first order you wrote post-operatively was have a trach tray, sterile trach tray at bedside. Patient's back in the room. You were that worried that you're going to have to perform a tracheotomy. First order on the chart. I mean, because that's what they tell residents. Okay, what post-op orders? Here, first one, boom. Any procedure's thyroid like that. Very careful not to extract the parathyroids on the back. It's what it looks like. Remember, typically simple cuboidal cells, round nuclei. When they use this, the follicular fluid, the colloid is easy to sell. In between here, you get little bits that aren't quite associated with it, that are not really a true area where we see the globulin or colloid form. And what happens is we relatively rapidly change that in the presence of iodine, that's why iodine is, even though it's a micronutrient, a mineral, we have to have it. So without the iodine, we can't make either T3 or T4. Okay. And as you can see, and you're going to see the structure of it, both are iodine containing amine hormones. Tyrosine, as you will see shortly. Every cell in the body, intracellular receptors, because you're going to see the symmetry next time of the molecule, and alters transcription and therefore translation. And by and large, they're all calorogenic. They increase metabolic rate and heat. So I'll stop it here. We'll pick that up next time. And we'll see everybody down at 141 for the end of this. That's where the lab's going. I've got the technology. And maybe we'll spend an hour. What? Downstairs. Wet lab next time over in Zoo.
What are we doing today in lab?
EKG, and I'm going to do some EKGs and finish the heart.
Okay.